Hi, my name is Emily. I'm a sixth-year APPE student at Western New England University College of Pharmacy in Springfield, Massachusetts. This final presentation for my current APPE rotation here is on triple whammy therapy. For the table of contents for this presentation, we're going to go through objectives, introduce triple whammy therapy, go through its mechanism, look at some primary literature about it, look at some patient adjustments, and then go through our takeaway/conclusion. Objectives. By the end of this presentation, you should be able to define triple whammy therapy and understand its mechanism, understand which patients are at highest risk using triple whammy therapy, and review how to apply therapeutic changes to avoid kidney damage. For the introduction, triple whammy therapy is the concurrent use of a diuretic, an angiotensin II receptor blocker, an ARB, angiotensin converting enzyme ACE inhibitor, along with a nonsteroidal anti-inflammatory drug or NSAID. The combination of these three agents can increase a patient's risk of acute kidney injury, or AKI, due to their different mechanisms working together. So diuretics are frequently used drugs that treat disease states like heart failure and hypertension, and they work by inhibiting the reabsorption of sodium at different spots along the kidney in order to increase fluid loss out of the body. The different classes of diuretics include loops, thiazides, and potassium sparing. For the ACEs and ARBs, they're working on the renin-angiotensin-aldosterone system, or RAS system. ACE inhibitors are blocking the conversion of angiotensin 1 to 2, and ARBs are blocking the angiotensin 2 receptors. By doing this, they reduce vasoconstriction and they reduce sodium and water retention. As you can see, the kidney is part of this system by releasing renin, which activates the system, and these ACE and ARBs are blocking it. NSAIDs are common medications used for both their analgesic and anti-inflammatory properties. They inhibit cyclooxygenase COX enzymes, preventing prostaglandin formation, resulting in decreased inflammation and relief of pain. Some NSAIDs are nonspecific to which COX enzymes they inhibit, while some have preferences for the enzymes that they inhibit. So aspirin specifically inhibits COX-1, while Celebrex or celecoxib selectively inhibits COX-2. So for the mechanism for the triple whammy therapy, it causes an AKI. So according to the KDIGO 2012 AKA guidelines, an AKI is defined as either an increase in serum creatinine by greater than or equal to 0.3 milligrams per deciliter within 48 hours, or an increase in serum creatinine to greater than or equal to 1.5 times baseline, which is known to or presumed to have occurred within the last 7 days, or a urine volume less than 0.5 milliliters per kilogram per hour for 6 hours. So for the triple whammy therapy, in using ACEs and ARBs, they're causing vasodilation at the efferent arteriole where fluid is flowing out of the kidney. They are used for this mechanism to be renal protective in some patients because it's allowing for a decrease in glomerular pressure. They also cause a reduction in proteinuria, so sometimes they can be beneficial for the kidney. However, when they're used at the same time as something like an NSAID, that's where some problems can result. So NSAIDs are causing vasoconstriction at the afferent arteriole, where fluid is going into the kidney. And as we said before, NSAIDs are blocking different COX enzymes than one another. However, their selectivity or non-selectivity does not diminish their effects on the kidney, despite the potential thought that selective COX-2 inhibitors like celecoxib could be safer. In a study done, they found that renal function declined equally between both selective and non-selective NSAIDs. However, it's important to note that another study found that low-dose aspirin, the 81 milligram tablets, they were not found to significantly decrease kidney function when they were used long-term for cardioprotection. So this is just an image kind of showing the use of ACEs and ARBs and NSAIDs together. NSAIDs are constricting the arteriole that goes into the kidney, and ACEs and ARBs are increasing the space and vasodilating it. So the kidney is unable to respond to a decrease in renal blood flow because the NSAIDs are blocking the fluid in, and ACEs and ARBs are letting a lot of fluid out. So that's just a visual with what we just talked about. And then when you add in the diuretics, it can be even more of a drop in renal blood flow. So diuretics are contributing through their effects on plasma fluid. They're promoting fluid loss out of the body, and this can even be more pronounced when patients are already hypovolemic. So look at them all together. First on the bottom right, NSAIDs are causing constriction, which is reducing the filtration rate. Diuretics are letting more fluid out of the body, again reducing the filtration rate. And then ACEs and ARBs are dilating the efferent arteriole, which is letting fluid out of the kidney, the third way that the filtration rate is decreased. So altogether, when you're taking all three of these medications at the same time, the body's renal blood flow drops. The body will then try to adjust for a decrease in renal blood flow by using the renin-aldosterone system. However, like we talked about before, the patient would already be on an ACE or an ARB that's blocking the mechanism of renin that the kidney tries to let out to kind of correct this. And since those drugs are blocking this pathway, the kidney is unable to compensate in this drop in renal blood flow. This causes an acute scenario of a drop in glomerular filtration with a rise in serum creatinine and ultimately the development of an AKI. So for the primary literature I looked at for this subject, I looked at a study which looked at the combined use of NSAIDs with diuretics or ACE and ARBs in the community, which was found to increase the risk of acute kidney injury. This study was done in 2015 and was a nested case control study, which aimed to assess the association of occurrence of AKI with the simultaneous use of NSAIDs, diuretics, and ACEs and ARBs. It included a cohort total of 78,379 patients who were prescribed an ACE inhibitor, an ARB, or diuretic. And they defined AKI as an increase in 50% of serum creatinine from baseline. So for the results, patients treated with triple whammy therapy had a higher occurrence of AKI compared to double therapy combinations. The number needed to harm with triple therapy was 158, while the number needed to harm with the single diuretic or ACE inhibitor / ARB use was valued at over 300, which shows that the use of these three agents together were more likely to cause an AKI than using each of them separately. Among the whole cohort, there was a higher incidence of AKI in patients who were over 75, patients with renal impairment, or patients who were specifically on loop diuretics or aldosterone antagonists. The takeaway points from this study are the use of triple whammy therapy is shown to increase AKI occurrence. The number needed to harm was found to be 158 people, and AKI was more likely in certain factors like increased age, decreased renal function, and the type of diuretic used. So to avoid this happening in our patients, we have to look at who would be high risk. So when should you be concerned to start triple whammy therapy in a patient? So patients who are elderly, patients with CKD or history of renal issues, patients who already have a history of an AKI in the past, patients who are volume depleted or dehydrated, and patients with severe cardiac or hepatic disease. So if you have a patient who's already on an ACE or an ARB with a diuretic, there are replacements that you can do to not use NSAIDs and maybe cause this triple whammy therapy AKI to occur. So you can use Voltaren or diclofenac gel, use Tylenol or acetaminophen, use steroid injections, or in the more severe cases, use opioids to treat their pain. For renal adjustments for all three of these types of drugs, first with NSAIDs, the KDIGO 2012 guidelines state for all NSAIDs, if the eGFR is between 30 and 60 milliliters per minute, they should be avoided with other disease states that increases risk of kidney injury, and for less than 30, they say to avoid use. Per the manufacturer guidelines, each of these drugs is a little different, but I think it's a good rule of thumb just to go by the guidelines and to follow what they suggest. For ACE inhibitors or ARBs, here's just a reference to look back to when thinking about adjusting or starting therapy in patients who may have some reduced renal function. And these are the adjustments for diuretics. And like I said before, the loop diuretics like furosemide and torsemide were found to have a higher occurrence of AKI. So in patients who may need to be on these three therapies or even just two of them, using a thiazide diuretic would be preferred if possible. So in conclusion, in patients who have those risk factors that we talked about before, reduced kidney function, elderly, volume depleted, adjustments should be made to avoid using the three agents together. And patients starting this therapy combination should have their serum creatinine monitored over the first few months of therapy and be counseled to stay hydrated while on the three together. And the study I mentioned above mentioned that it is more likely for the AKI to occur specifically within the first month. So it's super important if a patient is going to be on all three to monitor their serum creatinine over the first few months to make sure everything's all right. So for references, these are the list of them here. And any questions, you can contact me at emily.castle@wne.edu. Thanks for listening.